Rate and rhythm control in atrial fibrillation. Atrial fibrillation is the most common sustained cardiac arrhythmia, characterized by irregular heart rhythm and tachycardia due to disorganized atrial electrical activity. If untreated, it increases the risk of stroke, heart failure, and cardiovascular morbidity. Classification: paroxysmal, self-terminates within 7 days, often within 48 hours. Persistent, lasts more than 7 days or requires intervention to terminate. Permanent, AF is accepted as the patient's baseline rhythm. Management overview. There are 3 key aspects to AF management: rate control, rhythm control, and stroke prevention via anticoagulation. Acute AF management. If the patient presents with life-threatening hemodynamic instability, perform emergency electrical cardioversion. If AF onset is less than 48 hours and the patient is stable, consider rate or rhythm control. If AF duration is over 48 hours or unknown, prioritize rate control and anticoagulate prior to cardioversion. Rate control. This is first line for most patients unless they have a reversible cause of AF, onset is less than 48 hours and suitable for cardioversion, heart failure primarily caused by AF, atrial flutter suitable for ablation, or inadequate symptom control on rate control. Medications. These include beta blockers, for example bisoprolol, which should be avoided in asthma, rate-limiting calcium channel blockers, for example diltiazem, these should be avoided in heart failure, and digoxin, useful in sedentary patients, monitor for toxicity. Combination therapy, for example beta blocker and digoxin, this may be used if monotherapy is inadequate. Rhythm control. This is indicated in patients with a reversible cause of AF, new onset AF less than 48 hours, AF causing or worsening heart failure, atrial flutter suitable for ablation, or symptoms not controlled on rate control. Cardioversion. Immediate cardioversion. This is indicated if AF is less than 48 hours or there is hemodynamic instability. This can be electrical, preferred in unstable patients, or pharmacological. Pharmacological cardioversion. Flecainide, if no structural heart disease. Amiodarone, this is preferred if structural heart disease. Delayed cardioversion. For AF over 48 hours or unknown duration, anticoagulate for at least 3 weeks prior or use transesophageal echocardiogram to exclude thrombus. Then perform electrical cardioversion after adequate anticoagulation. Long-term rhythm control. Flecainide can be used in paroxysmal AF. Amiodarone or sotalol may be used in select patients. Rhythm control does not remove the need for anticoagulation if stroke risk remains elevated. Catheter ablation. Consider if rate or rhythm control has failed or is unsuitable. Pulmonary vein isolation is most commonly performed. AV node ablation with pacemaker insertion may be used in refractory cases. Patients should be anticoagulated for at least 4 weeks before and during the procedure. Long-term anticoagulation remains necessary post-procedure if the CHA2DS2-VASc score warrants it. Anticoagulation. All patients with symptomatic or asymptomatic, paroxysmal, persistent, or permanent AF and those undergoing cardioversion or ablation should be assessed for stroke risk using CHA2DS2-VASc score. The CHA2DS2-VASc score scoring system. Risk factor. Congestive heart failure, 1 point. Hypertension, 1 point. Age at least 75, 2 points. Diabetes mellitus, 1 point. Stroke, TIA, or thromboembolism, 2 points. Vascular disease, 1 point. Age 65 to 74, 1 point. Female sex, 1 point. A score of 0 in men or 1 in women means that no anticoagulation is needed. A score of at least 1 in men or at least 2 in women offer anticoagulation. Anticoagulation options. Direct oral anticoagulants, DOACs, for example apixaban and rivaroxaban. These are first line. Warfarin is used in certain cases, for example, valvular AF or mechanical heart valves. Valvular AF. Patients with moderate to severe mitral stenosis or mechanical heart valves require warfarin. Bleeding risk. Assess using the ORBIT score or HAS-BLED score. Optimize modifiable bleeding risk factors before starting therapy. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today